pattern?
I came to see Dr. Petrick because I was having extreme arm and neck pain due to a previous injury from a seizure that I had several years ago where I fractured my elbow, tore all the tendons in my wrist. A month and a half ago or 2 months ago, I was going through physical therapy. They weren't able to heal me, so he was my, should have been first choice, but was the next choice. Came back and he's helped me a great deal. I can straighten my arm out, which I couldn't do for the last 3 years.
So there's been some drastic improvement with Marcy. Just to kind of to touch on this situation, it by no means wasn't the fault of the therapist or the physical therapy that she was receiving. The active release component in which we do in this facility is extremely important, and it's oftentimes the one piece that's left out in the physical therapy program. It is absolutely impossible for tissue to function normally when there's a tear or a scar. And what a fibrous scar looks like is this. This is normal tissue, or should simulate what normal tissue looks like, and this is what happens after the body has responded to a stimulus or an injury. It starts to adhere and stick the tissue together. In Marcy's case, even though she was going and getting probably extremely good physical therapy, the component that was missing was being able to free up those adhesions so that the patterns of therapy would actually take effect or would actually be beneficial. So once we freed up the tissues, we could get the arm to lengthen. She did mention also that the fact that she was having seizures, those seizures were what's known as grand mal seizures and even a few petit mal seizures. That's important to know because the body goes into a state of flexion and stays in a contraction. When it stays in a state of contraction for a certain period of time, the myoactin, as far as the contraction, stays right there and the calcium doesn't replenish. So therefore, even when she comes out of the actual seizure, that tissue stays contracted. So we've been working on that. Also, what pursues after a seizure like that is a massive headache. She'll report that the headache feels across the skull, maybe even behind the eye. So blurred vision, your typical aura-like symptoms that you would associate with the atypical or atypical migraine. We've been able to kind of render those kind of almost obsolete in regards to how you've been feeling with those as well.
Oh yes, much better, much better.
So with that, one of the things we're going to demonstrate today is a dural tension maneuver that we're going to utilize. Around the brain there's a dura, and around the spinal cord there's a dura or a sleeve. Oftentimes a sleeve can be tight, oftentimes a sleeve can create and establish a headache. Can be also associated with some severe neck pain. So we're going to do some dural work on her, and then I'm going to work in the upper cervical, primarily the rectus capitis superior and inferior obliques, as well as some of the other occipital structures at the base, at the occipital ridge. We're doing that so that we can free up the skull so that it doesn't impinge any of those cranial nerves that come out of the skull at that location. So we'll start with the dural sleeve maneuver, and we'll kind of loosen that tension. We're going to have Brina come on her feet. You're going to lie on your back for me, please, with your head up at the end of the table. Brina, you're going to grab both of her legs when I tell you, and you're going to bring them up to the sky. Okay, you're going to go very slow with this. You're going to keep the feet together, and I'll take tension first. Marcy, I'm going to be putting your head down into flexion. Okay, it's going to seem like I'm really cranking on your head. Bear with me. It's not to touch the neck, it's to deviate the skull forward into flexion. We want to get some movement of the skull. My contact's actually going to be holding and kind of restricting that dura, which is that sleeve around the brain and neck. Okay? Excuse me, brain and spinal cord. What we're going to be doing is I'm going to drop you into extension. Very good. And I'm going to be taking my hands back here, darling. So again, I'm taking it right up at that occipital ridge. Okay, so I'm going to go forward, Miss Brina. We're going to bring this into dural tension. See how she's lifting her body? That's how much tension she does not want to go into flexion. I'm going to have her tuck her chin, and I'm going to leave this. Keep going, Brina. Be careful, good night. Nice and slow. We're going to hang right there, Brina, okay? I'm going to have you tuck your chin a little bit more for me. That a girl. And you could probably have seen that slight little deviation of that chin. Good hold right there. And a little bit more. And down. Okay, very good. Brina, hand me my ball. Okay. You alright? Okay. So she actually slid pretty well. As you can see, that skull started to deviate and flex forward. Extremely important because we want to kind of get her condyles on the atlas and the upper cervical to move. I want to get the skull to be able to translate and move. Again, working on these inferior and superior oblique muscles at the top, also with the rectus capitis major and minor coming in there as well. So we'll work this, again, keeping her rotating. She often has a tendency to feel, because of the burn in the tissue, that I'm actually pulling the hair. There's actually no hair pull. I'm not even actually sliding on the tissue to pull the hair. It's that sub-tissue that's causing that discomfort. Again, this is coming back for the inferior oblique. And again, and I'm careful to check for nystagmus of the eyes to make sure that the patient isn't, doesn't have a transischemic attack or even put her into a stroke. She does have a family history of some blood issues and some stuff like that, so we got to be real judicious. Be careful not to move the head when doing these maneuvers too fast, especially with patients who have had a history of seizures and things like that. Grand mal or grand petite, you just want to be careful in skull movement. I keep my hand off of the ear as to not to create any particular type of avoidance there. Good, right there. And now I'm working right side superior oblique. I'm going to bring it back for the right side inferior oblique, which you really can't see at this point. But what I am going to do is bring it back on that left side so that you can see it on film. I'm going to bring it now. This is inferior oblique, one of the major headache muscles. If anybody ever has a headache and has this work, typically the patient's going to report that there is definitely an improvement in their symptomatology associated with that headache. There's a lot of nerves come out of here from the vagus nerve, your cranial nerves or skull related, so there's a lot of structure to be careful with so you don't just go mashing tissue when you get into there. Having worked that, we're going to work the occipital frontalis, which is a muscle above the ridge. We're going to get into this tissue and kind of free it up as we move along. So we're going to bring her back into extension. We're going to have her raise her eyebrows real high for me for that occipital frontalis. And then what I'm going to do is I'm going to bring her back into flexion. Okay, come back for me, Marcy. Come back for me.
Come back.
And we're going to keep her down. She wasn't actually supposed to raise up on that. So
Sorry.
no, that's okay. That's okay. I did bad instruction. That's all docking her. So just keep your body nice and low. I'm going to have you just tuck your chin, sweetheart. There you go. Please tuck your chin. There you go. Keep your chin tucked. Now squint like you just had a bad lemon. Like squint your eyes as tight as you can. Good. Okay. Very good. So what ultimately that does is that it frees up that occipital frontalis muscle, so when she gets that headache that seems like it radiates over the top of her skull or behind the eye, it's real important that those fibers that I showed you, like in the mop, are released, and it frees up that dura, it frees up those adhesions so that headache dissipates. So she'll also say at times that my head will feel hot or you'll feel cold. Typically the sensation after treatment is going to be hot because you're increasing blood flow. Total normal sensation. So working with the shoulder on this patient, with Marcy, again, when she goes into a grand mal seizure, the wrists close in, she goes directly into flexion, and this is where she spends a good portion of her time during that seizure. It's no wonder that if you do that on anybody, that's actually going to be uncomfortable, and I'm barely pressing on her too, so she's come a long way from when she came in and we could only straighten the arm that much. So she's done a very good job of putting up with me over a very short period of time too. It hasn't as if we've spent a lifetime together. And let me add that this is the second time I've seen Marcy for symptoms. We've seen her for something else in the past. And currently now this is the method that we're going to utilize to treat this problem here. So what I'm doing right now is I'm working on the brachialis muscle in the bicep, where I've moved the bicep out of the way and I'm actually deep to it and underneath the bicep structure. So what I'm doing is I'm trying to get the brachialis to be free so that it doesn't bind that arm. I'm also working on the intermuscular septum in here, and I'm working on the tricep portion of the intermuscular septum. Again, this is where she climbs into when she goes into a seizure, is in this position. So oftentimes she'll tell me that this feels really good once we free up this tissue and it doesn't stay in that contraction. So she, and you'll see her kind of let me know she's feeling it. She'll kind of jump a little bit. She may even cuss and swear. I will remind you we're on camera, and I will show this to your mom. So if you swear too much at me, go ahead and bend that for me, please. There you go. And again, I'm working on the tricep right now. Working on all the structures. Very good, very good. There is some discomfort and some pain associated with some of the treatments, depending upon how long the tissue has been damaged, or the site and the severity of the actual image here. I mean, as far as the damage. The nerves run through this bundle. You got a sleeve that runs down through here. Ulnar nerve branches off and goes into here. This is the Tommy John area. Typically, if you ever, anybody that's a baseball fan, this is Tommy John. We're also going to work the flexor group of the forearm. Again, this is the superficialis, is the flexor of this forearm. We'll get to the profundus, which is the deeper version, but we're not going to have to open up the arm to do that. So we'll just, the profundus is treated like such. We bring the arm back, keeping the elbow bent, as just to put it into flexion. She loves this one, as you can tell, as she writhes in pain. And we're going to go into the brachioradialis. And I can feel a relative decrease in slide between the brachioradialis and the extensor group in the arm. So what we want to do is use the active release to allow this tissue to free up and to slide. So when the tissue has it can actually have the relative slide up from its side. And the interesting thing to note is that with the active release protocols, most of your treatment is actually fascia as opposed to just the belly of the muscle. So you're really trying to more treat an area rather than a structure. You're trying to treat the area between two structures as opposed to the actual structure, especially when the fascia is involved. So what we're doing now is, again, kind of going through some of these structures. I'm holding the brachioradialis superiorly and allowing the extensor group to kind of pass inferior, or kind of distally underneath my contact. So you'll see that this kind of travels in this direction. So again, I'm letting her let that tissue go. Notice there's no slide with my contact. I'm actually holding it and letting the tissue pass under my contact, as opposed to like a massage technique that you're actually working the tissue on top. This allows me to get very deep to the tissue. It allows me to work the structure that I'm wanting to work, as opposed to mashing all the tissue on top of it. Very specific movements here. Everything I'm doing I want to gain from her. So it's important that we kind of focus and control these movements. Again, notice how long the arm is right now. She's fully lengthened. That's great. None of that happened a few weeks ago. She couldn't even get the arm to 90 degrees. So we're working pretty good. She's a good patient. She keeps her appointments. She comes in with a smile in spite of the pain and the bad jokes. Right? Couple more. Okay, we've worked some of the structures in the forearm. Kind of got the gist of that in regards to what we're trying to do here, free up the nerves. The big part about this is the shoulder. When she goes into a grand mal seizure, that shoulder has a tendency to rise, arm gets flexed, and she gets down in this position. So her trap and the actual rotator cuff become affected by that. So what we're going to do is we're going to check underneath the armpit. There are 14 structures that typically make up the rotator cuff. It's important to be accurate, so I won't work all 14. I'm going to be real specific and primarily work the subscapularis muscle. That muscle's primary responsibility is to keep the humeral head down and back. So in a seizure, what happens? The shoulder rises, so it puts strain on that subscapularis muscle. So what we're going to do is we're going to free up the subscap and allow that humeral head to be down and back. So the more seizures that she may have, it's not kind of compounding this by in creating a rotator cuff injury. So we'll get into the subscapularis. It's a little difficult to see on camera because it's a structure that's deep underneath the armpit. We're going to bring it up over the head. She's going to pull her arm up over her head nice and slow. My line of drive for this particular maneuver is along the belly of that subscapularis muscle. If you keep crying like that and making those faces, nobody is going to come in here.
Try to disagree.
Okay, so we're going to go back into that subscapularis muscle. We got a few structures to treat, and then I'm going to let Marcy go. So right now I'm on the subscapularis muscle. It's pulling against my hand, and my line of drive is towards the rib cage right through here. So I'm kind of letting her take it. I'm going to let this body kind of do what it needs to do. I'm going to provide with a little direction, but notice I'm not pushing the arm down. So it's just a little bit of direction. trying to get her to maneuver the arm and give me a little bit more than what she really wants to give me. Very good. And if you'll notice, very, very, very subtly, look how much the arm has gone up. It's traveled all the way up. So from a situation where she has no extension of the arm, we can treat the subscap, and you'll see that now when she brings the arm all the way over her head, like a good patient, nice and slow, that tissue is now free enough that she doesn't have that brachial adhesion. Go all the way up over your head, all the way up over, show off for me, all the way up, and then it goes all the way up over the head. So it's really important for us to make sure those structures are free. We're going to check a little bit into the pec minor. Again, with the grand mal seizure, that humeral head rises up, and one of the structures that takes a beating is the pec minor muscle, which is right underneath here. And more than a treatment, what I'm doing is I'm palpating for some hardness, some tissue, some tension, and a little bit in the pec right underneath here. So we'll treat the pec minor, and we'll treat it this way. Drop the elbow, please. And we're going to extend, 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 and rotate. And that's pec minor. Good. Good. So, again, giving you the gist of what a treatment is, regardless of the patient's symptoms, regardless of the severity of the symptoms, it's incredibly important to be able to perform active release as soon as possible. So if it's an acute injury, such as like a sprained ankle, you're never going to work through the injury, you're always going to work to the injury, but as soon as you can get your hand on the structure and create some movement, you're going to start that healing process. Same thing with any particular type of injury, whether it be chronic or acute, the more hands-on you can get, the better and the faster that patient will heal. With a chronic injury, you're going to work through the scar, and with acute injury, you're going to work to the scar. So regardless of when they had it, or how soon they've had it, or how acute the injury is, as soon as you can get your hands on it, the faster that recovery is going to take place. So I'll go ahead and sit Marcy up right now. I'm going to scoot her all the way down on the end of the table. Now with this patient, it's one of the differences is that, especially with the seizures, is we want to free up this mid-back so that she allows herself to get back into extension. So freeing up the mid-back vertebrae is extremely important, especially when you're dealing with neck injuries or neck issues. When there's a thoracic cage, the patient will have a tendency to have that anterior head carriage where the head is forward. So what we do in our practice, is give our patients a lot of strengthening with scapular retraction, exercises. We put you on towels so that you can go home and rest. And I also do manipulations of that thoracic spine. Again, mobilization is absolutely critical to improvement, stimulation of the nervous system, and we're going to lean you back, darling. And we got one more. Okay. Okay, go ahead and stand up for me, face.